Welcome back to the deep dive. So, almost everyone has heard about wisdom teeth, right? Kind of rite of passage, almost.
It definitely feels that way sometimes.
But what if the story's, well, bigger than that?
Hmm,
We're going beyond just wisdom teeth today to really dig into all impacted teeth.
that's the plan.
What they are, why they cause problems, and what the science actually says about managing them. Think of it as your shortcut through the dental jargon.
Right. And while taking out impacted teeth, especially wisdom teeth, is super common for oral surgeons, modern practice really needs solid evidence behind those decisions.
Makes sense.
So our goal today is pretty simple. Equip you with the key info so you understand the nuances, understand what's happening in your own mouth perhaps, and feel good about the options.
Okay, let's unpack this then right away. When we talk about impacted teeth, it's not just any tooth that hasn't popped through yet, is it?
Exactly. That's a crucial distinction.
So what is the actual definition? What makes a tooth truly, stuck?
Basically, an impacted tooth is one that just hasn't erupted when it was supposed to.
Okay.
And crucially, it's reached a point where we really don't expect it to make it on its own anymore. It's past its developmental window.
Gotcha. So diagnosis isn't just, is the tooth there? It's about knowing the normal timeline.
Precisely. You need that context of normal eruption times.
Yeah.
And what's really interesting is the pattern we see.
Which is?
Generally, the teeth most likely to get impacted are the last ones to come in. It's kind of the reverse of the eruption order.
Huh.
So your wisdom teeth, third molars, top and bottom, they're number one by far.
Right, everyone knows about those.
After them, it's often the upper canines, those pointy ones near the front.
Okay.
Then the lower premolars, upper premolars, and sometimes the second molars.
Wow. So it goes down the line like that?
Pretty much. It's actually quite rare for your first molars or your front incisors to be truly impacted.
Yeah.
And baby teeth almost never happens.
Baby teeth almost never get impacted. That's genuinely eye-opening. So the big takeaway isn't just wisdom teeth,
Not at all.
but that the order gets flipped. The last ones in are the first ones stuck. And are we talking like significant numbers for these other sheath?
You nailed it. That reversal is key. And yes, absolutely. Big studies looking at thousands of people, Army recruits, school children consistently find many impacted teeth besides wisdom teeth.
Like what percentage?
Well, one study on Army recruits found hundreds of non-wisdom impacted teeth, mostly those upper canines. Another in Sweden found over 5% of kids had non-third molar impactions.
5%. That really puts it into perspective. It's not some super rare thing then.
Not at all. Wisdom teeth get the attention, but it's a much broader issue.
Okay, so the million-dollar question then, why? Why does this happen? What stops a tooth from just coming in?
Good question. We can sort of group the causes into two main buckets, systemic and local.
Systemic sounds like bigger picture stuff.
Exactly. Less common, body-wide influences. Think certain genetic conditions like cleidocranial dysplasia or endocrine problems like thyroid or pituitary issues. Even severe childhood fevers sometimes.
And that would affect more than one tooth.
Often, yes. When it's systemic, you might see multiple impactions throughout the mouth.
Okay, but you said local factors are more common. That's probably where it gets really interesting for most people.
Absolutely. Local factors are usually the main culprits, affecting just specific teeth.
So what kind of things are we talking about there?
All sorts. Could be a baby tooth just hanging on too long, blocking the path. Or the permanent tooth germ itself, the little bud, just starts developing in the wrong spot.
Like it's aimed wrong from the start.
Kind of, yeah. Or sometimes there's just not enough space in the jaw, what dentists call arch length deficiency.
Too many teeth, not enough jaw.
Basically. Other things too. Extra teeth, called supernumerary teeth, can get in the way. Or sometimes benign tumors, even just an abnormal eruption path, or conditions like cleft lip and palate.
Can we dive into some specific examples, like those canines you mentioned?
Sure. Maxillary canines, the upper ones, are notorious. They often get displaced either towards the roof of the mouth, palatally, or towards the lip, labially. And there's an interesting finding here.
What's that?
Research by Jacoby suggested that when canines are stuck towards the lip, there often is a space problem. Not enough room.
Makes sense.
But surprisingly, when they're stuck towards the palate, towards the roof of the mouth, lack of space usually isn't the issue.
Huh. So why are they stuck there then?
Well, he theorized maybe there's actually extra space in the bone up there, or maybe issues with the teeth next door, like the lateral incisor root, which normally helps guide that canine down.
So the guidepost is missing or faulty?
Something like that, yeah. It's complex.
And what about second molars? You said they're less common.
Less frequent, yes. But when they do get impacted, often it's because The wisdom tooth behind them is in the way, acting as a physical block.
The wisdom tooth strikes again.
Often, yes. But here's another twist. While lack of space is a factor, one study, Bondemark and Ziopa, found something surprising, which they found that in their study group, a whopping 75% of impacted second molars had no clear physical barrier blocking them. Not on x-rays, not clinically.
75%. So space isn't always the answer there either.
It strongly suggests it's not the only answer, definitely. Other factors must be at play.
Fascinating. Okay, let's circle back to the main event then. Wisdom teeth. Third molars.
Right. The most commonly impacted, they're the last ones to try and erupt.
And they have a pretty wide window for showing up.
They do, up to maybe age 24 or even 25. But here's a key point. Their position usually doesn't change much after age 25.
Okay.
But, and this is important, an 18-year-old whose wisdom tooth looks impacted on an x-ray, they might still have a decent chance, maybe 30%, even 50% of it, erupting fully by their mid-20s.
Wow, 30 to 50%. That's higher than I would have guessed. That really impacts the whole wait-and-see approach, doesn't it?
It certainly adds a layer to the decision-making, especially for younger patients without symptoms.
Before we get into when to intervene, can you quickly walk us through how they're supposed to develop the normal timeline?
Sure. So the little tooth germ for a lower wisdom tooth, visible on an x-ray around age 9.
Okay.
The cusps, the pointy bits on top, start mineralizing around 11. The crown, the part you'd see fully formed by about 14.
And the roots?
Roots are maybe half formed by age 16. While this is happening, your lower jaw is growing longer.
Creating space.
Exactly. And that growth helps the wisdom tooth rotate. It usually starts angled, then tips up into a more vertical position. Ideally, it settles into place by age 20 or so.
And most that are going to make it are in.
About 95% are fully erupted by age 24.
So why do so many not make it through that whole sequence? What goes wrong?
Primarily 3 big reasons. First is something called differential root growth.
Meaning?
Basically, the roots are the engine for eruption.
Yeah.
If the front part of the root system and the back part don't grow at the same rate...
It throws off the direction.
Exactly. If the front, the mesial root, doesn't develop enough, the tooth might stay angled forward. It's a mesioangular impaction. It doesn't make that final upright rotation it needs to.
Okay, that makes sense. What's number 2?
Second, and this is a huge one, inadequate bony arch length. Just not enough room.
Simple lack of space.
Yep. Studies consistently show people with impacted wisdom teeth tend to have, on average, larger teeth overall compared to people whose wisdom teeth erupt fine.
Interesting. So it's not just jaw size, but tooth size too.
Yeah, it's the ratio between them. If your jaw just isn't long enough for that last molar, it's likely to get stuck. And even if there seems to be space, sometimes really dense bone around it can prevent eruption.
Right. And the third reason?
Finally, sometimes it's just retarded maturation. The tooth's development is lagging behind the jaw growth.
So it's slow off the mark.
Kind of. And here's a slightly counterintuitive bit. By age 20, an impacted wisdom tooth with roots that are still developing is actually less likely to erupt than one in a similar position but with fully formed roots.
Really? Why is that?
Because that final root development provides some of the eruptive force and influences bone resorption. If development stalls, it might lose its chance. The timing is critical.
Wow, okay. Timing, space, and root growth. It really is a complex sequence. So once we suspect there's an issue, how do dentists actually figure out what's going on under the gums? How do you diagnose it?
Diagnosis itself is usually pretty straightforward for permanent teeth. It's a combo approach.
Clinical exam plus x-rays.
Exactly. You look at the mouth, is the tooth missing where it should be? Then you take x-rays to see exactly where the unerupted tooth is and how it's positioned.
Simple enough.
Usually.
Yeah.
But if a dentist finds multiple impacted teeth or impactions in really unusual spots, like first molars,
That rings alarm bells.
it should. It signals, hey, maybe we need to look for a bigger systemic reason behind this.
Gotcha. And those x-rays are key for planning treatment, I imagine.
Absolutely critical, especially if surgery or orthodontics is on the table. We need to know the tooth's 3D position.
How do you figure that out from flat x-rays?
There are standard techniques. One is the tube shift method, taking a couple of x-rays from slightly different angles.
Okay.
These rely on a principle called the SO War Rule. Stands for same lingual, opposite buccal.
SLO bull rule. Catchy.
It helps us tell if the tooth is closer to the tongue side, lingual, or the cheek side, buccal, based on how it appears to move between the two x-rays.
Clever.
And for really complex cases, we're increasingly using 3D imaging, like cone beam CT scans. Gives us a much clearer picture.
Makes sense. Now, specifically for lower wisdom teeth, are there signs on the X-ray that predict if it might still come through?
Yes, two factors consistently stand out. First, the angulation.
How tilted it is.
Right. A tooth lying completely flat, horizontally, or strongly angled forward has a much lower chance of erupting than one that's mostly vertical. Distoangular angled backward is kind of intermediate.
Okay. And the second factor?
Space. This is probably the biggest one. Is there enough room between the back of the second molar and the upward curve of the jawbone, the ramus?
How much space is enough?
Ideally, you want to see space, at least as wide as the crown of the wisdom tooth itself. If the tooth looks bigger than the space available, or it's angled way off vertical, full eruption is pretty unlikely.
Okay, that's clear. So, diagnosis done. What are the paths forward? What are the general treatment approaches?
It really depends on the tooth.
Hmm.
For many non-third molar impactions like that canine we talked about, the ideal goal is actually to get it into the mouth, into a normal working position.
So save the tooth, if possible.
Definitely. That often involves a team approach, orthodontics to make space, surgery to expose or attach something to guide it.
Right.
But for teeth with really poor eruption potential, or if there's already pathology like a cyst, and this applies to almost all impacted third molars, then removal is usually the way to go.
And that decision, especially for wisdom teeth, can be controversial sometimes.
It can be, particularly regarding prophylactic removal, taking them out before problems start. There's been a lot of discussion, and modern surgeons really need solid evidence-based reasons. It's not automatic anymore.
Okay, that's a key distinction. The goal for a canine might be rescue, while for a wisdom tooth, it's often removal. So let's focus on wisdom teeth. When is removal clearly indicated?
Well, if you already have problems or symptoms caused by the wisdom tooth, the decision is pretty clear-cut. Remove it.
Makes sense. Pain, infection.
Exactly. But the debate really centers on removing them before symptoms appear. And it's important to note, most problems actually arise from partially erupted wisdom teeth.
The ones that are halfway in, halfway out.
Precisely. Those are trickier to clean and more prone to issues than ones completely buried under bone and gum.
Okay. So what are the main reasons or indications for taking them out, even prophylactically?
Let's run through them because this is where some really important knowledge comes in. First, and maybe the most significant update in recent years, is periodontitis or gum disease.
How so?
We used to think that little flap of gum over a partially erupted tooth, the pseudopocket, was harmless. We now know that's absolutely not
It's
true.
real gum disease.
It is. Even in young, healthy people, these partially erupted teeth create areas where harmful bacteria thrive. This leads to deeper gum pockets, bone loss, not just around the wisdom tooth, but often affecting the second molar right next to it.
Wow.
Yeah, having a visible wisdom tooth doubles your odds of having gum pockets 5 millimeters deeper. And importantly, removing these teeth, especially before age 25, usually helps the gum health around that adjacent second molar recover.
So getting them out early can prevent long-term gum damage.
That's a major justification, yes.
Yes.
Second indication, pericoronitis.
That sounds painful.
It often is. It's inflammation and infection of that gum flap over a partially erupted tooth, usually a lower one. Bacteria get trapped under there. It's actually the most common reason for wisdom tooth removal after age 20. It counts for maybe 25–30% of extractions.
Okay, what else?
Dental caries, cavities. It's just incredibly difficult to keep the area around a partially erupted or impacted wisdom tooth clean.
Food traps.
Big time. So cavities pop up, either on the wisdom tooth itself or, sometimes worse, on the back of the second molar next to it. That causes about 15% of extractions, and it gets more common with age.
All right. Gum disease, infection, cavities. What about orthodontics?
Right, orthodontic considerations. Now, here's a crucial clarification. Impacted wisdom teeth are not generally considered a major cause of your front teeth getting crowded after braces.
Oh, that's a common belief, isn't it? That wisdom teeth push everything forward.
It is, but the evidence suggests that late crowding is more about overall arch length changes. However, impacted wisdom teeth can obstruct planned orthodontic movements. They can physically block other teeth from moving where the orthodontist wants them.
Okay, so they interfere with treatment.
They can. Also, they often need to be removed before orthognathic surgery or corrective jaw surgery. Taking them out beforehand, usually 6–12 months prior to allow healing, can make the jaw surgery itself easier and more predictable.
Got it. Any other big reasons?
A few more. Prevention of odontogenic cysts and tumors. The little sac of tissue around the crown of any unerupted tooth can sometimes degenerate into a cyst, most commonly a dentigerous cyst. Or, much more rarely, it can develop into a tumor. This happens in maybe 1–2% of extracted wisdom teeth, usually in people under 40.
Yeah.
It's a definite reason for removal if detected.
Okay, cysts and tumors.
Then there's root resorption of adjacent teeth. A wisdom tooth pushing in the wrong direction can actually eat away at the root of the second molar.
Seriously, damage the tooth next door.
It can. Sometimes the second molar can repair itself if the pressure is removed, but severe resorption might mean losing both teeth.
Ouch.
Also, teeth under dental prostheses.
Yeah.
If you're getting a removable denture that rests on the gums and there's an impacted tooth just under the surface,
Problem waiting to happen.
likely, yeah.
Yeah.
As the bone under the denture reshapes over time, that tooth can become exposed, painful, and inflamed. Better to remove it beforehand. For fixed bridges or implants in older patients with deep asymptomatic impactions, it's often okay to leave them.
Okay, 2 more.
Prevention of jaw fracture, especially in contact sports. An impacted wisdom tooth creates a weak point in the angle of the jaw. It's a common spot for fractures from impact.
Makes sense for athletes.
And finally, sometimes, maybe 1–2% of the time, removing an impacted wisdom tooth resolves unexplained jaw pain, even when there are no obvious signs of problems on the x-ray. We don't fully know why.
A diagnosis of exclusion, almost.
Kind of. But it's crucial to tell patients that pain relief is not guaranteed in those cases.
That's a very thorough list. So on the flip side, when is taking them out not the best idea? When do the risks outweigh the benefits?
Excellent question. Because it's definitely not always the right call. The decision involves carefully weighing those benefits against the risks of surgery.
So what are the main contraindications?
Primarily extremes of age. Let's start young. For kids, say 8 or 9, removing a developing wisdom tooth bud just because it might become impacted later, that's generally not recommended anymore.
Why not? Used to be done, right? Coronectomy.
Not coronectomy, but prophylactic enucleation, removing the whole bud. Yes, it was done sometimes, but the consensus now is that the tooth might still erupt normally, so early removal isn't justified.
Okay, so don't jump the gun on young kids. What about older adults?
This is a big one. As you get older, especially over 40, things change. Healing tends to be slower. Surgery often leaves a bigger bony defect. The bone itself is denser, less flexible, making the extraction harder and increasing fracture risks slightly.
And recovery is tougher.
Generally, yes. Longer recovery and higher rates of complications like dry socket, infection, and nerve issues. So the rule of thumb now is, if you're over 40 and you have a wisdom tooth that's fully impacted, completely covered by bone, no communication with the mouth, no symptoms, no pathology on the x-ray.
Leave it alone.
Probably, yes. Just monitor it periodically with x-rays. Yeah. The risks of removal often outweigh the benefits in that specific scenario.
Okay. Age is a factor. What else?
Compromised medical status. Significant health problems, serious heart or lung disease, bleeding disorders, maybe poorly controlled diabetes or epilepsy, can make elective surgery, like removing an asymptomatic wisdom tooth, too risky.
Need to talk to the patient's doctor.
Absolutely. Close collaboration is key. And finally, the risk of surgical damage to adjacent structures.
Like nerves.
Exactly. If the impacted tooth is positioned very close to important nerves, like the one to your lower lip and chin, inferior alveolar, or the one to your tongue, lingual, or maybe right up against the sinus,
Removal could cause permanent damage.
there's a higher risk, yes. If that risk seems substantial, leaving the tooth might be the more prudent option. Or this is where coronectomy comes in.
Ah, okay. Explain that again.
Coronectomy is a technique specifically for high-risk lower wisdom teeth. The surgeon removes only the crown of the tooth, intentionally leaving the roots behind, buried beneath the gum.
To avoid disturbing the nearby nerve.
Precisely. It significantly reduces the risk of nerve injury, and there's good evidence to support it in select cases.
Interesting alternative. So assuming the decision is made to intervene, what are the actual techniques? Let's start with those non-wisdom teeth first.
Right. For those, like impacted canines or premolars, the approach varies. Sometimes it's simply surgical exposure. The surgeon uncovers the tooth crown, maybe removes a bit of gum or bone to give it a path to erupt naturally.
Just open the door for it.
Essentially.
Yeah.
And studies show this can work quite well. More often, though, it's exposure combined with orthodontic bonding.
Attaching something to pull it down.
Exactly. The surgeon exposes the tooth, and an orthodontist glues a small bracket or button onto it. Then, using braces, they apply gentle force to guide the tooth into its proper place. This needs prior orthodontic work to create the space first.
Okay.
A key point here is being careful not to expose the CEJ, the neck of the tooth when enamel meets root, when attaching things, as that increases risks like root resorption.
Got it. What else for non-wisdom teeth?
For impacted second molars, surgical uprighting is an option. Best done when the roots are about 2/3 formed.
How does that work?
Usually involves taking out the wisdom tooth behind it first, if it's there, to make room. Then the surgeon carefully tips the second molar upright into position and splints it temporarily, keeping it out of the bite while it heals.
Physically moving the whole tooth.
Carefully, yes. Another option, less common, is transplantation,
Moving it to a different spot.
or into the correct spot if it's impacted elsewhere. You carefully extract it, place it in the prepared socket, stabilize it, and then usually do a root canal later. It can be surprisingly successful, especially for canines.
Wow. And if none of that works or isn't suitable, removal.
Then it's removal. The principles are conserving bone, sectioning the tooth if needed for easier removal, and protecting nearby teeth and nerves. Upper palatal canines often need the crown removed first, then the root second. Lower premolars usually come out from the cheek side, being mindful of the mental nerve. Upper wisdom teeth, due to thin bone, are rarely sectioned, and never with a chisel too risky for displacement.
Okay, now for the big one. Removing impacted wisdom teeth. How do surgeons figure out how difficult a specific case will be?
Several factors go into assessing difficulty. The two absolute biggest are depth of impaction and patient age.
Deeper means harder. Older means harder.
Exactly. A tooth completely buried in bone, full bony impaction, is significantly harder than one just covered by gum, soft tissue impaction. And for any given depth, surgery is always more challenging in an older patient due to denser bone and less flexibility.
What other factors play a role?
Angulation. Mesioangular, tilted forward, is usually least difficult. Distoangular, tilted backward, is often the most difficult because access is tough.
Okay.
Also, the tooth's relationship to the jaw ramus and the second molar, the root morphology fused. Conical roots are easier than multiple curved divergent roots, and, interestingly, the size of the follicular sac around the crown. A larger sac can actually make access a bit easier.
Right. So walk us through the typical surgical technique. What are the steps?
Okay, generally speaking, first, create an adequate soft tissue flap. Gently lift the gum tissue to expose the bone underneath. An envelope flap is common, maybe a three-cornered flap for deeper access. The absolute priority here is avoiding the lingual nerve on the tongue side.
Careful flap design.
Bone removal. Careful, atraumatic removal of just enough bone to expose the tooth so it can be removed. This is done with a high-speed surgical drill and irrigation, not a chisel. Bone is usually removed from the top, occlusal, cheek, buccal, and back distal aspects down to about the neck of the tooth. Again, avoid removing bone on the lingual side.
Protect that nerve, then the tooth itself.
Tooth sectioning. Often the tooth is divided into smaller pieces using a burr. This allows for removal with less force and less bone removal overall. We usually cut about 3/4 of the way through towards the lingual side.
Divide and conquer.
Precisely. Then delivery of the pieces using specialized dental elevators. After the tooth is out, meticulous wound debridement is crucial. Cleaning out the socket thoroughly with a curette, smoothing any sharp bone edges, and irrigating heavily with sterile saline.
Get all the debris out.
Absolutely. Finally, closure. The gum flap is repositioned, usually with stitches, achieving primary closure.
Okay, that covers the mechanics. What about things like antibiotics and steroids around the surgery?
Good question. Let's talk antibiotics. While wisdom tooth surgery is technically clean contaminated because it's in the mouth, the actual rate of post-op infection is pretty low in healthy people, maybe 1 to 5%.
So routine antibiotics aren't needed just to prevent infection?
Generally, no. Prophylactic systemic antibiotics aren't considered necessary for infection prevention in healthy individuals undergoing routine removal. However,
There's a but.
they do reduce the incidence of dry socket or alveolar osteitis, but, and this is key, local measures seem just as effective for preventing dry socket. Things like preoperative chlorhexidine mouth rinses, copious irrigation during surgery, sometimes placing topical antibiotics directly in the socket. These work well and avoid the systemic risks of antibiotics allergy resistance.
So local measures are preferred for dry socket prevention?
Often, yes. Now, steroids are a different story. Their use is pretty widely accepted.
For what purpose?
To minimize swelling, trismus, jaw stiffness, and pain after surgery. An IV dose during the procedure, maybe followed by oral doses for a day or two, can significantly improve patient comfort.
Like dexamethasone.
Exactly. Dexamethasone or methylprednisolone are common. Short-term use has minimal side effects for most people, though there are contraindications like active ulcers or infections.
Do they affect dry socket risk?
There's some limited data suggesting they might slightly increase it, but the benefit in reducing swelling and pain is generally considered substantial.
Okay, surgery done. What's the typical recovery like? What should patients expect?
Right, the post-op course. Some things are expected. Minor bleeding or oozing is normal initially, controlled by biting on gauze.
Okay.
Swelling is definitely expected. It usually peaks around day 2, maybe 3, then gradually subsides over 5 to 7 days. Steroids help limit it. Ice packs mainly provide comfort.
Stiffness.
Stiffness or trismus, difficulty opening wide, also peaks around day 2 and usually resolves within a week or so. It correlates with swelling and pain.
And pain itself.
Pain starts as the local anesthetic wears off, peaking in the first 12 hours typically. It's managed with analgesics. NSAIDs like ibuprofen are great, maybe combined with acetaminophen, sometimes codeine combinations for more severe pain. Taking the first dose before the numbness wears off is key.
Stay ahead of it.
Exactly.
Huh.
And interestingly, the biggest predictor of post-op pain severity is usually the length and difficulty of the surgery itself.
Makes sense. Now, what about things going wrong? Complications.
Thankfully, serious complications are uncommon, but it's important to be aware. Infection rates are low, as we said, maybe 1.7, 2.7%. About half of those are localized superiosteal abscesses, little pockets of pus under the gum flap showing up 2 to 4 weeks later, usually easy to treat. Significant infections needing hospitalization are rare.
Okay. What else?
Sometimes a tooth root fragment might fracture during removal and be tricky to get out or get displaced. If a small uninfected root tip is left deep in the bone, often the best course is just to leave it. It usually integrates without problems, and aggressive attempts to retrieve it can cause more harm, like nerve damage.
Leave well enough alone sometimes.
Sometimes. Then there's alveolar osteitis, the dreaded dry socket.
How common is that, really?
Incidence varies widely in studies, maybe 3% up to 25% in some reports, often higher for lower wisdom teeth. It happens when the blood clot breaks down too soon, exposing the bone, usually around day 3 or 4. Causes significant pain and bad odor.
Risk factors.
Smoking is a big one. Oral contraceptives, too. Prevention involves those local measures we discussed, rinses, irrigation. Treatment is mainly palliative, focused on pain relief while it heals.
Nerves. We talked about the risk.
Nerve disturbances, yes. Injury to the inferior alveolar or lingual nerve happens in roughly 3% of lower wisdom tooth removals. The vast majority are temporary paresthesias, numbness, tingling.
But some can be permanent.
Unfortunately, yes. While most resolve, some minor permanent sensory changes can occur, especially with nerve compression injuries. Radiographic signs like the nerve canal looking narrowed or interrupted near the root tip warn the surgeon of higher risk. And that risk absolutely needs to be discussed with the patient beforehand.
A vital conversation. Any really rare things?
Very rare, but possible. Displacement of an upper third molar into the infratemporal fossa, the space behind the jaw, or the maxillary sinus. Thin bone makes this possible. Retrieval might be attempted later, or if it's in the sinus, sometimes via a different surgical approach. If it's asymptomatic, sometimes leaving it is considered. And extremely rarely, fracture of the mandible itself, usually associated with deep impactions in older patients with dense bone, often from excessive force, requires immediate fixation.
Okay, really emphasizes careful technique. So thinking long-term now. What does all this mean for the health of the gums and bone around that second molar after the wisdom tooth is gone?
That's a critical long-term consideration.
Yeah.
Periodontal healing, the health of the gums and bone on the back of that second molar, is definitively best under specific conditions.
HR.
When the impacted wisdom tooth is removed, before it becomes exposed in the mouth.
Okay.
Before it starts causing bone resorption on that adjacent second molar.
Right.
And ideally, when the patient is as young as possible, early removal, before problems develop, leads to the best healing outcomes for that second molar.
So if a wisdom tooth is partially erupted, even if it doesn't hurt?
The evidence suggests it should probably be removed promptly, especially in younger patients, because it's very likely already harboring a destructive periodontal lesion that you simply can't clean effectively. Removing it allows for optimal healing.
But what about those older patients, over 35 or 40, with completely impacted asymptomatic teeth?
That's the group where generally leaving the tooth undisturbed is recommended unless pathology develops. Removing it in that older age group carries a higher risk of creating persistent deep gum pockets and bone loss on the back of the second molar. The healing potential just isn't as good.
What about bone grafting in the socket after removal? Does that help?
Generally, routine bone grafting is not considered necessary or beneficial for most wisdom tooth sockets. However,
Another but.
It might provide some benefit for specific patients, usually those over 25 who already have pre-existing periodontal defects on the second molar caused by the wisdom tooth, like deep pockets or attachment loss, especially if the impaction was horizontal or mesioangular. But it's not a routine procedure for everyone.
Wow. What an incredibly detailed journey. We've gone from the basics of what an impacted tooth even is, through all the reasons why, the diagnosis, the treatments from saving teeth to removing them, and right through to healing and long-term health. It really underscores making evidence-based choices.
Absolutely. It's about understanding the specifics of each situation, the risks, the benefits, and the patient's individual factors,
So, for everyone listening, perhaps this deep dive prompts some reflection.
hopefully. Maybe it leads you to reevaluate some common assumptions about procedures like wisdom tooth removal, and perhaps equips you with better questions to ask your own dentist or surgeon. Active engagement with your health knowledge is always powerful.